Thank you for the kind introduction. I'm Julia Chen from Hong Kong, as the chairman has introduced. And as a new faculty member joining the department, basically, majority of my work are based on clinical works. And I would like to carry on with my talk with a more clinical approach. I have nothing to disclose financially. So dry eye disease, as mentioned by our previous speakers, is a very serious problem. The global prevalence is occurring in rating to even like 30% of the population. In Hong Kong, the prevalence is around 7.7 to 30%. The current model of diagnosis is thinking that dry eye disease can be classified into aqueous deficient, evaporative, or mixed kind of disease. Why dry eye disease is a problem clinically is because of the ambiguity in nature in terms of dry eye disease. As illustrated in the OSDI, the symptoms of these kinds of patients are often very ambiguous. They cause sensitivity to light, grittiness, irritation, which mimics a lot of very serious and sinister condition. And often it can be misdiagnosed by many doctors and eventually causing patients dissatisfaction. The challenges of dealing with dry eye disease is that the patient's expectation is often mismatched. Because patients are so bothered by those irritating symptoms, they perceive themselves having a sick role. They thought to themselves that they have something very serious, but when ophthalmologists disregard their symptoms and just prescribe them with lubricants, they are often unhappy and unsatisfied. So this is a few pictures of the lubricants commercials in Hong Kong, illustrating how common this problem is and how big the market is because of the dry eye disease not being able to be treated adequately in our clinical settings. So what are the symptoms in dry eye disease? It causes punctate epithelial erosion, more often seen in patients with aqueous deficiency, or the patients with meibomian gland dysfunction, illustrated with telangiectasia over the meibomian glands. And when we try to express the glands, the meibum expressed are often like toothpaste and very mucoid in nature. So in order to cater the problem of the mismatched management time and patients' report, and we have established a tertiary clinic solely dedicated to dry eye disease. It's a combination of nurse-led clinic as well as a corneal team, which we combinedly assess the patient. The aim is that we better diagnose patients with underlying pathophysiology, causing better patients' report. We follow up the patients and try to triage the patients into suitable treatments. So the comprehensive approach starts with nursing assessments, doctor's assessments, finally with provision of treatment. Usually in a clinic's time, the nurse will take an hour to take a very detailed history, performing all the dry eye-related tests and questionnaires for the patient, for 3 particular patients, and then these patients will be slipped into our doctor's clinic as a very few last cases where we can adequately assess those patients. So this is the assessment form we have performed. You can see that the nursing staff take a lot of effort in filling in all the forms with taking a very detailed history in a very standardized format. And then they also help us to perform all the tear breakup time, Schirmer's test, slit lamp examination, try to express the glands. They had a lipid view report and also keratography 5M reports as well. And as last, the nurse will try to suggest some non-medical treatment for the patients. So what are the results with our clinic, which has been operating for already 4 years? So through this dry eye clinic, we have a cumulative of 151 patients with an average age of 61, with female predominance. And you can see that these kinds of patients often are primary dry eye patients without underlying disease, such as Sjogren disorder or secondary Sjogren related to rheumatoid arthritis or SLE. So one of the very significant findings we find in these kinds of patients is that when we trace back the records, we find there is a highly significant, higher proportion of patients with high ANA theta. So on the left is literature quoting the healthy populations. You can see that in healthy populations, there's still around 15%, around 10% of patients with an ANA theta of above 1 to 160. But then, in these primary dry eye patients, they don't have any prior Sjogren's syndrome. They don't have secondary Sjogren's syndrome. Nevertheless, there's a high increased patients with high ANA theta level. And fundamentally, these patients are different from those with low ANA thetas. They have low tear breakup time, and their Sherman tests are significantly different. However, in terms of other parameters, such as OSDI, conjunctival staining in redness, tear film, and also percentage of incomplete blinking, and also redness, there's no significant difference. So how does this result help us to provide a better comprehensive treatment for the patients? So before anything, we start with something with basics. We tell the patients education pamphlets are distributed to them. Detailed explanation of how ocular surface lid mask hygiene can be performed for them. Of course, we start with lubricants, and some of the patients who need immunomodulation will provide them. And then we also offer treatments to them. So how do we also did a retrospective analysis, finding that especially in our Chinese cohort, after a session of thermal pulsation system, namely lipid flow, there's significant improvement in these kinds of parameters. Since, as I have mentioned, patients with high ANA thetas, they are fundamentally having a lower tear breakup time. So that's why these kinds of treatment will benefit them significantly. So in conclusion, anti-nuclear antibody in dry eye disease may pave a fundamental for many basic science research that maybe I can collaborate with the chairman in the future. And this illustrates how we can translate our clinical findings into future scientific analysis. Thank you.
Yeah, thank you very much, Dr. Julia Chen. Any questions for Julia? I have one question. I want to ask about the ANA test. So yes. Now that is a standard test in your clinic, so most of the primary dry eye, you would send them for this test?
Yes, I will do that for them, yes. And someone will have asked, why do I use ANA as a biomarker, but not other tests? Because when reviewing these patients, I find that there's no other raised titers in these kinds of particular primary dry eye patients. For example, namely double-strand DNA and other kinds of biomarkers, I don't see an increased trend. But there's only just the ANA that is raised in particular primary dry eye patients.
And this test, is it specific to primary dry eye or any other conditions would also show positive?
Okay. In current literature, there's no analysis on dry eye patients on ANA and the relationship of primary dry eye. There are studies previously in Taiwan who looks at the ANA titers in Sjogren's syndrome patients, but never on primary dry eye patients. Thank you so much.
Yeah. So is there more questions for Dr. Julia Chen or even other previous speakers? Yeah. So if not, then thank